I was talking about extending access to genetic testing, so that's germline genetic testing, so trying to find patients who have a hereditary risk of cancer, increased predisposition to cancer. We first talked about ovarian cancer patients where we know 10 to 15% of them have inherited mutations in the BRCA1 or the BRCA2 gene. We've set up a programme at the Royal Marsden called the Mainstreaming Programme, where we train non-geneticists, so clinicians who are oncologists or surgeons in the GYN team, to be able to undertake that testing themselves. And that's great for patients because it means they don't need an appointment in genetics, and it speeds up the whole process so they have a result quickly, which can sometimes be very important for directing their care. And it also allows us then, if we find a mutation in a patient, to offer to see their relatives so that we can determine if they've also got that mutation, and then offer them ways to reduce their risk of cancer. We've been talking a lot about the mainstreaming programme, and we have a lot of material that's freely available on the mainstreaming website. So other people are taking this on board, and maybe not in exactly the same way, but it's a good framework for setting up this kind of testing in other places. There's the benefit to the patient themselves, so if we have an ovarian cancer patient where a mutation is identified, they may be able to access then a targeted treatment such as a PARP inhibitor. But also it's important that they can then have other family members tested. So if a patient's sister has a test and she also carries the mutation, she might choose to have prophylactic surgery to have her ovaries and fallopian tubes removed after she's had her family, and to prevent her risk of ovarian cancer in the future. Well, that's could be massively important. No, not really. Not everybody chooses to have risk-reducing surgery, but it's there as an option. And also, if you have a BRCA mutation, we also know that you have an increased risk of breast cancer, and those patients can access a breast screening programme that's where you have annual screening rather than 3 yearly as the normal breast screening programme. I think when everybody thinks about hereditary predisposition to gynae cancers, they think about BRCA, but Lynch syndrome is also important. The highest risk of cancer is colorectal cancer, but there's also a risk of endometrial and ovarian, so we want clinicians to be thinking about patients that have a family history that sort of looks like it might be Lynch. And we also talked a little bit about panel testing, because there's lots of panels now where you can test lots of genes, but it's really important that if you're going to test a gene, you know that what changes in that gene are disease causing, and you have something that you can do about it. So you don't just test because you can, you test because it can be clinically useful.